why don't we dive in? And Louise, if you want to take the introductions, that'd be great.
Happy to do that. Thank you very much. So it's a pleasure to introduce Victoria Wood, who is the curriculum manager in the Office of UBC Health. But she has been, I think it's now 64 interviews that she has conducted across the province to get a better idea of what is going on in team-based primary care in the various jurisdictions, as well as primarily to find out what the continuing professional development needs are. So to give you a little background on how this came about, I was at a meeting and had an impromptu conversation with somebody from the Ministry of Health and asked him, does the province actually know what's going on? Given that this is a priority for the Ministry of Health, do you know what's going on, both in terms of within health authority, and more importantly, what professional development is being provided to these groups, because we know from the literature that you do need professional development to help teams become effective and efficient, etc. The answer was, great question. That therefore led to a project at the Ministry of Health, the Office of UBC Health, and UBC CPD to do an environmental scan of activities across the province, and more importantly of the CPD that is being delivered and the needs that people would express. So Victoria, I think, can just take it. She has been the main person to conduct a whole series of interviews, and the slide deck will present some preliminary findings from all of that to share with you. I think the intent here is to really, one, share this with you, but also to what extent does this resonate with you? And we'll have time for questions and comments as soon as she gets through the slide deck. So Morgan, I'm going to pass this over to Victoria now.
Okay, great. Well, thank you very much, Louise. If I can just ask you to change slides, thank you. Oh, there we go. So in terms of what we really accomplish, as Louise mentioned, provide a little bit of an overview of the project itself and the work that I've been engaged in over the last month and a half. We'll describe a little bit some of the team-based care, primary care models that are popping up. Thank you. In terms of conversations that I'm having, we'll primary care teams that are really coming out with this stakeholder engagement needs assessment process, and then describe some of the emerging themes and recommendations for an integrated provincial CPD strategy for primary care teams that we will be submitting to the ministry, and get your input into that as part of our stakeholder engagement. So next slide, please, Morgan. So this project, as Louise mentioned, sort of came out of that conversation that she had with the Ministry of Health, and has become a collaboration with our UBC Health, the Ministry of Health, and UBC CPD. And we formed a steering committee that's really led the stakeholder engagement process and what this needs to look like. But more importantly, we brought together an advisory group that has representatives from the health authorities, professional associations, the GPSC, and that group helped us identify who were the key individuals with whom I should be speaking. And I actually started out with those members of the advisory group. And over the last 2.5 months, I've been having one-on-one or one-on-3 interviews. Some people have brought together groups of key individuals within their groups to speak with me over the phone. And it's been a real snowball technique. Everybody with whom I've spoken has sent me on to 3 to 5 other people. And so as Louise mentioned, I'm at about 64 interviews at the moment. And that's been with key representatives from the health authorities who are involved in primary care transformation, as well as the development and delivery of continuing professional development to support existing and emerging teams. I've spoken with key individuals from the professional associations who are involved in the development and or delivery of continuing professional development or tracking of continuing professional development, and really found that there's not a lot going on there in terms of team-based primary care, but had an opportunity to get their sense from a disciplinary perspective about what the needs of their profession were. I've spoken with quite a number of individuals from various divisions of family practice. And then some of the most fruitful conversations have been with individuals who are on primary care teams themselves. And so what they've been doing is letting me know what they would have liked to have had at the outset of their team development, as well as what they see their continuing needs to be. So if you can just change slide there. The goal of this project, as we mentioned, is a recommendation report that will be submitted to the Ministry of Health and outlining of an integrated approach to continuing professional development. And we're really getting a sense of what that integrated approach needs to look like based on the stakeholder engagement process. So we're hearing that it needs to be something that's provincial, that there's resources that are available broadly. There's some jurisdictions that have a lot of continuing professional development resources and capacity for supporting teams, while others don't. So that ability to share and build and access what's available, as well as the need to sort of have something that addresses the gaps. So there's a lot of really great things being done provincially to try to support teams, but that we need to figure out comprehensively what teams need from the outset all the way to sort of being a high functioning interprofessional team, and that's a journey that they need support in terms of being able to get there. One thing that we've gotten throughout this stakeholder engagement process is the need and importance for this project. So the number of people who said to me, wow, oh my goodness, thank goodness, I'm so glad you're doing this, and this work is so needed, particularly from those who don't feel like they have the internal expertise or resources to be able to effectively support their existing as well as emerging teams. So the next slide, please. So during the conversations that I had, it was really interesting because people would say, well, what do you mean by team-based care? And it was really clear from the individuals with whom I spoke that they had a strong vision of what team-based care means, and recognized, even the practicing teams recognized, that we're not necessarily always practicing as a team, even though we might call ourselves a team. And so from the individuals that I spoke with, we heard that this needs to be more than just a physician and an MOA, that there needs to be other persons involved. It was very loud and clear that this is not one size fits all. So it's based on patient and practice needs, and that it's more often than not really designed to meet the most complex patients that a particular practice or community are dealing with. And some are taking a practice-based approach and looking at patient panels and what professions they need to have involved to meet those complex needs of their patients within their own practice, or others are forming kind of more of this network approach and looking at what are their common patient panel needs and the community needs, and how can they address those together, and working with the health authority teams to kind of bring those in. This is a lot more than co-location. There's recognition that co-location is not actually necessary or a prerequisite or a requisite for this, but that even when we do have the fantastic opportunity to bring different healthcare providers together, if they're not adequately supported and changing the way they practice, they can quite often end up continuing to practice in their silos. And there was a number of teams that really were honest about the fact that they call themselves a team, but they're continuing to practice independently. It's a very referral-based system, or they have sort of their separate roles and they don't really communicate or collaborate. And they recognize that there was this need for coordination and care and processes to support collaborative decision-making, but they often didn't know how to do that. And so they needed these opportunities to come together for common learning so that they could learn those new ways of practicing, because they recognize that this is actually different from traditional practice models. So if we can go to the next slide, please, Morgan. So I sort of alluded to the emerging team-based care models that I came across in the course of this work. So there are a number of physicians across the province within a particular region or community that are coming together. They may be a group practice or a group of solo practices or a group of group practices. They come together, they recognize that they have some common patient issues and common needs, and they actually pool their resources to hire one or more allied healthcare professionals. And so then that individual will spend half a day or a full day in each of the involved clinics. And that's always based on an analysis of their patient panels and what they feel will best meet their common needs. So it might be a diabetic nurse, it might be a social worker, depending on their patient needs. There's often groups of community practices that are brought together and linked then to a common community health team. And again, that's often based on a specific patient population that would meet their needs. So it may be a group that focuses on frail elderly or mental health, depending on the community itself. A lot of health authority staff are being redeployed to family practice teams. And again, that just depends on the availability of the health authority staff and where they would fit best in order to meet the needs of the community. And the health authorities are working really hard to figure out where those staff fit and would be of most benefit. A lot of times allied health professionals are given space within a family practice, and this is used to improve attachment and increase capacity. So that's often a situation where there's a team that practices alongside a family practice. So you can have the individual professions that may come in. It might be a psychiatrist, it might be a pharmacist. The patients are booked for one day a week, a specific day of the week with that individual profession, or they go into sort of those co-located health authority teams within that group practice. And then there's health authority teams that have salaried physicians, and that are being brought together to address the needs of very complex patients as well. So a lot of, and quite a number of mental health teams and teams working with mental health and substance use issues across the province, and some really great teams. And actually through another project, some of those in person and actually filmed them sharing some of their stories. So that was really great. So those are some of the models that we see emerging. So the next slide, please. So all of the teams with whom I spoke really highlighted the fact that you didn't naturally just become a team because you were brought together. One key thing was the fact that we needed to have the right people on the team. There were quite a number of teams I spoke with who talked about they had some attrition at the outset because they just didn't have people who were committed to a team-based care approach, or it wasn't really a way of practicing that worked for them. So getting the right people at the table and giving them an opportunity to come together and build as a team and build trust and build respect was really important. They recognized the need for role understanding and negotiation. So very often when, for example, a health authority staff is redeployed to a team, that role looks very different in a primary care setting to maybe the setting that they were coming from and previously practicing in. And so having an opportunity for the team to work together to figure out what those roles are going to be and how they're going to work together. Also, there might be a particular physician or group practice or existing team that recognized the need for a particular role and had an idea of what that would look like. But then when that individual shows up based on their competence or really how the team evolves and what works best, having that chance to really think about that collaboratively is important. Discussing the way that they're going to address patient needs and doing that collaboratively. And one of the things that came across really strongly, particularly with some of the teams that are very focused on specific vulnerable populations, is having a common commitment to what we mean by patient-centered care, by things like having a common commitment to trauma-informed care, cultural competence, and things like that, and being able to have those conversations at the outset and learn about those collaboratively. There was the recognition that they actually need to learn new ways to practice. They can't practice their old ways and still be a team. So they actually need to think about that differently. And having the time through continuing professional development to collaboratively develop these care processes. So learning about team-based care processes and then having a chance to implement that collectively in relation to their unique context is really important, as well as time to establish new communication and collaboration strategies and figuring out how they're going to work together. So those are some of the needs that we heard from those teams. And then the next slide. So in terms of emerging themes and recommendations, one thing that's really key and related to that idea of attrition and making sure that you have the right people on the team is ensuring that all team members have a common understanding and commitment to team-based care before forming the team. And this is something that we can do in a unidisciplinary way with groups separately, is providing that we need common language around that, and everybody needs to have a common commitment and understanding to exactly what we mean by teams. And then once you identify the team, making sure that continuing professional development is delivered to the entire team is really key. And unfortunately, there's a lot of challenges around that in terms of remuneration and people's time and how their days are structured. But everybody I spoke to recognized that those are both challenges to the way a team practices together, and they need to be addressed for both that reason as well as their ability to come and learn together. We need to make sure that the continuing professional development opportunities are provided early on. So people said, we need to do this before we're interfacing with patients so that we have that role understanding, we're building that trust, we're building that respect, we're talking about care processes, and they're actually bringing patients into the process because there's a lot of patient education needed for them to be comfortable with this new model. If I call up and you're suggesting I see a different healthcare provider and I'm used to seeing, my family physician, and now you're suggesting that I see a social worker or a nurse practitioner or a diabetic nurse, I need to understand why that is and be educated around the fact that this is actually going to benefit me and is enhancing my care. And so getting the teams to actually think about that. And then the teams, and as well as the other individuals across the board that I spoke with, really talked about the fact that these can't be one-offs right at the beginning, that there's ongoing team processes and development that happen that need to be reflected on. And so continuing professional development needs to be ongoing and integrate a CQI, quality improvement approach, so that teams are having the opportunity to collectively reflect on how they're functioning, what they may need to improve upon, and given some resources to help them do that. And actually implementing those changes would benefit from a coaching or practice support type of approach. That's all I have to say, and would really like to hear from you about what resonates in terms of what I've said and what we're hearing, and what your views are about the need for continuing professional development for primary care teams.
So back to you, Morgan, to probably facilitate the discussion.
Yeah, absolutely. I'm going to stop sharing my screen unless anybody wants to jump back to a slide. I can turn it back on. That'll just make it a little easier for me to see whose hands are waving and who's got questions.
Well, this is William Cunningham.
Jump in.
So quick thing, could you send these presentations just as attachments as email attachments? Because I'm on the phone, and because Zoom isn't accepted by Island Health on its system.
Okay.
That's why.
So I'll just double check with Louise and Victoria.
Yeah.
They're nodding their heads, so yes, absolutely.
Yeah, okay, thank you. The other thing I want to say is this is incredibly timely, certainly with the divisions of family practice, through the collaborative services committees, all these GPSC things. This is exactly what we're talking about. So this is fantastic. Is this totally linked to the PSPs that are coming out on team-based care? Is it the same group making them up, or how does it fit in with those, I wonder?
So that's one piece of the puzzle. Our office of UBC Health has worked closely with the practice support program on the small group learning sessions that will be coming out. And I know waiting anxiously for those. The foundation session was piloted. Those sessions needed to be revised. So those are, from the last conversation that I had with PSP, being reviewed, and they're hoping to have the next two, I think, available in March. And so we're linking, so from this work, that's kind of one piece of the puzzle. So there's an environmental scan component to this project that identified what are the resources and available in different groups involved in the development and delivery of continuing professional development to support very specifically primary care teams around that sort of teamwork piece. There's a lot of other CPD out there that's sort of more broadly applicable or more specifically applicable to specific, clinical topics, but looking specifically at that team-based care support piece. So where we've kind of got, as part of this project, an environmental scan that will identify what all those resources are, those PSP small group sessions being one of them.
So that's excellent. I've got a second question that can wait after other people had their turn.
Sure, I see Bob's raise his hand.
Thank you for the excellent work that this shows. And actually this is, I hope, going to demonstrate the importance of this particular venue in terms of breaking down some of the silos and finding common cause. Because I'm a little bit disappointed that our paths didn't cross earlier. You mentioned the CQI and the approach of CQI as being an important piece of moving it forward. I, with a nurse practitioner, co-chair a group under the BCMQI looking at CQI specifically related to multidisciplinary teams. We did a very extensive literature search, which we can certainly make available. But more significantly, I think we were able to identify a number of highly functional teams. So we're looking at existing teams that are high functioning and have conducted a series of both key informant interviews and focus groups to identify the dynamics that you alluded to in terms of how does any given team move from the place it is now to a place of, shall we say, increased quality and thereby increased satisfaction. And what we've done is completed the feasibility / pilot phase of that, but there's some interesting stuff there that would be quite shareable. And it will be incredibly helpful if we are connected as we move on to the more formal phase, not the more formal phase, the more expanded phase of the kind of things we're doing. Because CPD in its best manifestation is helping an individual, but in this case, the team move more towards what they aspire to do. And that's always hard to measure, and it's often devolves to a kind of a QA approach as opposed to a CQI approach. And so some of the nomenclatures and a particular lens that we've got, much of which is represented in your studies, might be helpful to have a discussion sooner rather than later. We're going to be having a meeting sometime in the next couple of weeks. So it'd be really helpful if we could talk before then, because that could help shape our future move.
Perfect. Thank you, Bob.
That's very, very much what we're hoping with these open webinars. So that's great. And I'm going to...
There was a question, it's Louise, there was a question on the chat about using
Yes.
the IHC competency framework. And yes, certainly the Office of UBC Health has produced a number of different series of workshops, et cetera, that uses that competency framework. So there are different tools out there that use it.
And if I can just add to that, I think that framework's really being used as a foundation by many. We have online modules focused on that, and the practice support program, small group learning sessions, use that as a foundation as well.
Yeah, so I just happened to see that. I think it was Dr. Ross.
Yeah, and then at least you've asked as well about the slide deck. I think we answered that question. We'll make it available.
Yeah, I did. Yeah, make it available sliding. You know, some of these things being referred to, it would be really nice if somebody collected those attachments and sent them to all of us that are really interested in this subject. I do have a second question. So I do in front of me have see all the people who actually are participating on this, or in theory responded, including the people from the Ministry of Health. So you're probably really aware, and Morgan, I know we sent you an invite, this exercise being done down at the Ministry of Health on population-based needs planning, and which is agnostic to providers. So it's really, really important that people like from this particular project that you're working on, and who have got a really good understanding of this team-based care and what's being done and what the possibilities are, and actually participating in that, just to make sure that everything is considered.
Yes,
it's more a comment than a question.
No, and thank you for the link earlier to those people in the ministry. It's certainly something that we've been talking about now.
Okay, well that's I hope you can come, because I don't like being the only doc there.
I'll do my best. I'll take it offline and check back with you about the date again.
Mm-hmm. Okay.
And then the other comment about sharing resources, that's absolutely part of what we're doing. You know, certainly these sessions, but there'll be an access on the web as well for some of the documents and resources and some digests of those materials too. Just not, it's not live yet. Yes, Alyssa, go ahead.
Thanks. I have so this is really great, and one of the things that people probably know is happening is that divisions of family practice locally, different divisions, are already going ahead with beginning to implement team-based care in a variety of different ways, and we're all engaged in a process right now, which is a bit of a staggered process, but to submit applications for significant funding collaboratively with the health authorities to GPSC. So, you know, the first wave has just gone through. There will be another wave in a month or so, and then another one in the summer. So my question is about the slide deck we just got presented, and Dr. Wooler referenced some another literature review. Divisions of family practice typically don't have capacity to do a lot of literature reviewing and research of that nature. That being said, many of us, and I know for sure the Victoria Division, are extremely committed to building programs that are evidence-based. And so we've done a little bit of literature reviewing on team-based care and primary care networks and that sort of thing. But it sounds like there's been a lot more rigorous work done, and that documentation, that data would be extraordinarily useful to us sooner rather than later. I know for one that in our division, I would like to be able to build our plan based on this kind of information rather than on just, you know, the sort of more skinny kind of work that we've done on that end. And similarly, you know, I don't know how aware people are, but again, I'll only speak about Victoria, but in Victoria, groups of GPs are quite eager to get going, and we've got at least one building full of GPs that are now developing a network and starting to talk about building teams of GP to GP with allied health and so on and so forth. They're very eager and they're moving quickly. And so, you know, again, trying to bring some information to them that can prevent, you know, can kind of help them to not fall into the traps that you know exist, and also really direct them in the most positive way, because if people have a bad experience, if these early adopters have a bad experience at this stage, it might make it very difficult for anyone going forward.
Yeah, those are good comments, and we're trying to collate as quick as we can, for sure. I mean, obviously, I have a bias being in your division.
But I think, Morgan, based on our discussion earlier on this morning, what the ISU is if you go back to the original concept of the ISU and the different phases of team-based care, the first one is, so we're thinking of doing this. How do we even start, right? How do we approach it? How do we understand our patient population, et cetera? And that is the work that Morgan's currently engaged in doing. We'll have all the tools necessary. You can have conversations beforehand, you know, depending on where people are. Once you get to the point of having, you know, a team identified, and that's where we actually do have, this is where the Office of UBC Health, and as I mentioned on the first webinar, we're working in close partnership. This is not saying that, okay, you got to go here for this and there for that we're trying to avoid that. We're basically saying this is one-stop shopping that you sort of get funneled through. And so teams that already are farther along, that might require specific professional development to address various aspects of their functioning, that's where, I mean, Morgan would funnel you to Victoria, because we actually have the ability to go out and to do some work. And then the third phase will be the evaluation, which is going to be probably we're going to work on that at the same time. So we don't have to wait till everything is up and running and perfect. I think there are opportunities, and I think in part it will help us all learn as we engage with various groups, because this is probably going to be fairly iterative, would be my suspicion. Morgan, was that a fair answer?
Absolutely.
Okay.
Absolutely. We're not going to have everything spit polished in the ivory tower. We want to get it started and learn collaboratively. Bob, I see your hand up, and there's one question online. So I'll go to the online one. It's been sitting there for a few minutes, which is, so what does the leadership structure look like? And for physician leadership, what tends to be the time commitment split between clinical and administrative work? So that's a tough one. It's partly, you know, how long is a piece of string question. because it depends on the size of the team, I guess.
I mean, I'll take a stab at that because I've worked in various teams. Leadership structure will be very dependent on the context, the area where you're working. There'll be some places you actually will engage very closely with the community, and you may have a society formed. And I saw that up north in one of the smaller communities that will take on a significant leadership role around and how it functions. Other times, I think the most important thing is that this is not purely physician-led. That from the get-go is going to backfire because you can't really engage all team members if this is once again just driven by the docs, to be perfectly blunt. The time commitment will again depend on what you need and how you can deploy. So again, if it's not just one person, if it's a shared kind of leadership model, then your time commitment isn't as great. How to get this going does require a fair amount of work. I don't know if Selena Laurie's on the phone or on the screen, or if Steve Bierman are, but they can tell you that it will often take a few champions to get this moving, and it will take some time, a time commitment that isn't always paid for again. So there's no one easy answer to this particular question.
Yeah, I just as an anecdotal story, in our team-based practice, we have leaders in the major professions, and each has some administrative time each week. It's a matter of a few hours, and then we have a lot more team meetings than your typical family doctor's office. Where I've been to places where it's sort of, my research study was the first quote unquote team meeting they've ever had in their office in 13 years. So there's a lot more of that, which is very good. When you're setting up, it's more than that for sure. Bob, I'm going to come back to you.
Oh, just in terms of Lisa or anybody else, we're certainly happy to share the lit review, share the lens and perspective of how a team might see itself, either through a lens or in a mirror. And we've got some graphics around that may be helpful. And then some of the preliminary studies, we're happy to do that. But one of the things that occurs to me with this discussion that we've just had is that to a certain extent, this is a conversation about creating new teams, when in fact teams exist all over the place. One of the, so I think what our studies and engagement might add to this is existing teams and how they have formed and how successful ones have measured their success and their sustainability. Because I think taking a particular lens and defining a team in a certain way, either the hegemonic dynamics or any other aspect of it ahead of time is interesting, but it's not what we do, but I think it's that what we do would dovetail with that approach. Rather than, sort of speculating too much about, we have to have these conditions before the team starts. It's trying to look at the teams as they exist. And what we did specifically was to look at leadership teams. And we spent some time with the entire senior leadership of Northern Health. We spent some time in the Comox Valley around the specific topics and in one of the large city hospitals in terms of their navigation team. So there's different levels, different teams, but there's a certain level of commonality. If we can get our language together and our lit reviews and other things efficiently done, then I think the sharp pointy end of the divisions can really make some inroads. So I'm anxious to look forward to that, and perhaps Victoria, if you want to call me and we could pull in Bev Mitchell, who's the main administrator at ACMUI, and my co-chair, we could perhaps just have a brainstorming discussion of how best to do that.
As part of the project, I actually have met.
William, can I just say something?
And have a further conversation. That would be great. Thank you, Bob.
Okay, good.
So it's William. I just want to say real quick things. To whoever was speaking just a moment there ago, I think for a lot of family physicians at this point in time, we're not talking about the existing teams or even the team-based care with community health services. We're talking about de novo teams starting up in good old fee-for-service family practice. And I think those kinds of submissions are going in now. And that's why it would be really nice if somebody could get together all these references so that people like Elisa and people like me can actually just read over these really quickly, and just the existing literature. So we're actually, I know there are big teams already, and that we're, Morgan works, I'm one of the funders for his teams. So, but we're not, we're really talking about de novo stuff, or at least, you know, the basics. The second thing is, I do know that UBC Nursing School now has a curriculum for nurse in practice. And something like that would be really good for someone on your leadership team here to share with us. And then the other thing is, one of the biggest obstacles to making this a reality are actually the dollar funders. So I mean, who's going to pay for these things? GPSC. I mean, who's going to hire these people and so on? That's stuff we really need to know now, or yesterday actually, not tomorrow. So it's just that's really key. Anyway, bye.
Well, thank you. We do have Sabrina Wong. She's not on the call today, but she's one of the co-applicants in the ISU. So she's a nurse, School of Nursing, and then cross-connected to us in family practice. So we definitely have
the one who did that. Yeah, that's the person
so,
I was referring to. It would be great if you could send us her stuff too.
Yeah, so she's been part of this from the beginning, which is fantastic. So I'll make sure, I'll invite her to, she's on the list to present at some point. I'll try to move that one up a little bit. And the funding talk is an interesting one. We know we can't avoid that, and we want to talk about it. And we know it's also not anything that we as an academic group have, you know, direct influence over, but try to find the right people to come and talk about that. I think will be really a key piece. And so
I totally agree. I think we do have to talk of it. And yes, some of us do have influence over that. So I think it's really important to talk about it so that we can then go and do the work.
Well, and just to add to that, I'll just say that as someone who's got some responsibility for the application.
Alyssa, could you speak up a little bit, please?
Oh, sorry, sure. Is that better? I don't have a microphone, so I'm just yelling into my speaker. I think to William's point, and you know, understanding that this group doesn't have leverage around funding, but to so that it would be nice for us to know, those of us who are applying for funding, particularly through GPSC, to know that they've been informed about what is actually the evidence behind team-based care, so that the goals that we identify as evidence-based goals are in line with us to be applying for.
Morgan, this is Maureen.
Yes, Maureen, you figured out how to put your hand up.
I figured it out.
Yeah. There we go.
So what I'm just trying to get a sense of, so for those of you who don't know me, I'm not a family physician, but I am on faculty in family practice. And my background is a physiotherapist, but I actually do a lot of systematic reviews. I publish systematic reviews as part of my work. So I'm used to doing a lot of searching, and if I can't do it, there are resources at UBC. So I guess what I'm trying to get a sense of, because this is a community of practice, I mean, would it be benefit to have a session on searching, or do you actually, you know, want more one-on-one, or as a group, should we actually do a systematic review on the evidence if that hasn't already been done? I'm just trying to think of really practical ways to support everyone in the community of practice.
Thank you for volunteering, Maureen. We'll stop there. Thank you. We'll just end this. Actually, Victoria has very humbly not mentioned the review that she's been working on, and we have borrowed all of the literature that she has.
Yeah, that wasn't a review. That was actually I provided the references that we used to develop.
Yeah, so I mean, sorry, to be clear, I wasn't suggesting a systematic review.
From a curriculum development perspective, rather than more of like a systematic.
Yeah, no, it was not a systematic review, but there is a body of literature that has been collected. And right now, Susan and Paula, who are also on the call, are pulling that all into a reference manager, and then we're going to start collating and synthesizing the abstracts and such. So that should be available. I think it would be great to do some review, but really thinking on what would the need be for the group.
Please do it.
Well, in some ways that, so this is Louise, another project, I mean, this is everything sort of comes together, looking at CPD and team-based care more generally, not specific to primary care. But if you do look at systematic reviews, Cochrane's done some for team-based care and patient outcomes, it's really difficult to find those kinds of studies. That's the trouble, because we're not all defining a team the same way. You have different patient populations. It's a bit, like applying a practice guideline to your patients, because they are a bit different. So I'd be curious, Maureen, if you were ever, if you could do a quick and dirty to see if there's much out there, but we weren't able to find very much. But I think the feeling is there's enough. There are enough studies, maybe not systematic, not really good randomized control studies that would fit the Cochrane bill of pass, but there's enough out there that has, I think, been used over the years to help guide the development of family health teams in Ontario and the work that's been done in Alberta, Nova Scotia, et cetera, that we've probably got enough to go on, particularly around, the elderly and some individuals with specific chronic illnesses. And I think there's just sort of the sense of, we know as family doctors, we can't do this all by ourselves. And then we know that our patients are being punted from place to place to place. And so, there's some of that. We also know that poor teams or bad communication and lack of collaboration are definitely linked to adverse outcomes. So that literature is very clear. So it's almost like the flip side of not doing it. Hence, whether it's worth investing in a lot of time to do a systematic review, I think more importantly is to figure out, how do we do it? And how do we benefit from the work Bob has done and the work that, because Victoria also found in talking to some teams that had actually managed to go, they would love to share what they're doing, but they have no place to do that, right? We have no system in BC that allows anybody to share anything. And that, again, is also what we're trying to do. So that's kind of a long answer, Maureen, to your comment. I don't want to dismiss the idea of a systematic review, though.
I think a different kind of review would be useful. A scoping review is probably a better fit.
Well, actually, in fact, Morgan, I was thinking about a realist for you, because I think if Alyssa, if I understand what you're asking for, are sometimes things that aren't necessarily in the literature. So it's those implementation factors. And oftentimes people don't report what didn't go well. But I think so some of the literature might not be there, but a realist review may pull that out. And I'm not suggesting that I do one. I'm actually just trying to figure out ways that we can help support as a community of practice, to try to at least have some sort of repository of information. And if there truly is that much information, you could do a review of reviews.
Okay.
I see Fiona's got her hand up, and Joni's got a comment about a new $150 million fund. So let's go to Fiona first, and then Joni.
Yeah, I hope you can hear me okay.
Yeah.
It's great to be in a forum where people are talking about this, and I would really echo some of the comments that have come out already this afternoon. One, just the real diversity in what those teams are. And the piece around the evidence is important, but there's, I think, certainly in the community, this feeling of wanting to get on with it. A little bit of the ivory tower thing, and at least I comments about, family physicians in the community just wanting to figure out how to do it. And I wonder, it makes me wonder, I think the piece that I've heard, and I would agree with, is that there's real benefit in looking at what existing teams and the high functioning teams, why are they working, and tapping into those people. And I would almost wonder whether part of the key elements that was listed in one of the slides actually really includes a coach or a mentor, not just to sort of talk about trust and respect and how to work together, but to deal with the challenges ongoing of how you do it and what people have struggled with already.
Those would be some of the pieces coming up. I'm going to start to invite some of the other groups that are ahead of us on so what were their experiences, and Bob certainly in his study has got a wealth of that information as well.
And I'll just add a bit about the sort of de novo team bit. I think that in general, for fee-for-service practice, which I think we acknowledge is in a crisis in a lot of the province, there, I think, is a key to physicians working with nurses. And by and large, that hasn't happened in a fee-for-service world. So how to do that?
Mm-hmm. Yep.
William, I just want to go on the speaker. Oh, okay. I'll just say, yeah. This is fantastic. If this is the location where you're going to have this information, that's great. I don't need a big academic thing. I just need to inform myself. I need it before Friday because that's when some of these. I mean, this is how timely this has to be, because the divisions of family practice, the health authorities, the CSCs, these expressions of interest are going in now. So the ratio I used in the application, or I used the South Island Division of Family Practice is using for theirs, is they want 1 nurse in practice for every 5 physicians. Is that the right number, the wrong number, is the right model? We're just pulling these things out of the air a little bit based on a few people's personal experience. But we really need this now. So doing some great big research study on everything in the literature, that's not what we need. So that the lady who talked earlier, the physiotherapist, that kind of info, if you could even share it with me personally, that would be fine. But I think everybody actually would benefit from it. So if we could put the more stuff in there, and I'll just read in the evenings instead of reading a novel before going to bed, that's how timely this has to be, because we're kind of doing things a little bit backwards system-wise. And so the more we have to think about, the better.
Bill, it's Louise, and I can't help but comment on this. I realize that suddenly, you know, the tap's been turned on and everybody's sort of scrambling to put a cup under to catch the water so that they know how, I guess, so that they want to drink from it. But I think we have enough information to help hopefully get away from what you, I mean, I have to say, I cringed when you said that there's a group of physicians who want 1 nurse per 5 physicians. That's the wrong way. I can tell you right now. It should be turn it around and say, whom are they caring for? What are the needs of the patients?
Exactly.
And then figure out the type of health professional. It is not just to have nurses being running around and helping physicians. That's not team-based care.
So that's the whole point I'm making, because the way these submissions go in, that is the twist on it. That's why I'm actually involved with this population-based, needs-based planning project at the Ministry of Health, because then you can actually say, patient, this is the blue matrix column they sit in, what kind of team would you ideally want to wrap around it? And then you say, well, how do we go and make that a reality? But that's not the reality of the world we are working in. Yes, that project has its product on August the 1st, but these these kind of EOIs are going in now. And that's why the more you can inform it, the quicker we can speed this process up. The more often people say what you're saying now in a really nice way, then that is the message that has to go forward, not only to the physician groups who are applying, because and the Ministry of Health, but that's what's needed. So that's why I think we need product.
Well, it's in part, and all of you who are on this call you may be involved in some of these proposals that are going in. You know, get your voice in there. Physicians don't necessarily need to have a whole bunch of stuff. They can turn around, and many of them have EMRs now. They can start doing an analysis of the patients for whom they're caring, and they can just stop the traditional way of doing things. I personally, and I think the ministry does understand this, I don't think any of those proposals would get funded. So, you know, you're better to sort of stop it now and get people to do it the right way, even if it's as quick and dirty, if the timelines are really short, but at least use the right methodology, even if you can't get it perfectly right.
Then put the methodology out there.
Message heard, William. We'll work towards helping with that.
Yeah, I just wanted to echo that unfortunately, I totally agree with you that it should not get funded if there's no basis for justifying a ratio like that. That being said, it probably will. And that's the reality we're working with, is that I don't think that the people, and I'm thrilled that you have confidence in the ministry. I can't say I share that. You know, because it's not the evidence I've seen. They do not appear to understand much about this. The other problem that we have, and again, people have spoken about the fact these can't just be doctor-led teams. Again, totally agree, because we know that from what we know about teams in general, let alone in health. We know that you can't just have one profession dominating. That being said, the challenge is that a lot of this work is being done through divisions of family practice, which has built a model of physician leadership.
Yeah.
And so shifting the script to true team is extraordinarily challenging in an environment where so many GPs are actually on the verge of quitting. You know, we're talking about a population of professionals who are very, very burnt out. So we, you know, sometimes our only currency to get people to the table is to ensure that, you know, to reassure them that you're going to be leading this. Don't worry, no one will take advantage of you. So that's kind of the dance that on the division end we're trying to navigate. So again, any kind of evidence or guidance or anything at all that can help us make the case for a different way of doing things, different than what people are assuming. Because right now, from what I've seen, and William certainly reflected on, things are going down the same old track. And you know that if you do the same old thing, you're going to get the same result. And then people are going to be freaked out and wonder why we didn't get something different.
Yeah,
So, and we're already down the wrong track. So we need to get this out. And so I appreciate, I'm not saying people need to just hop to it. I just mean as collectively, we need to recognize that we're at a lot, there's some risk right now that we could maybe work together to mitigate.
Yeah, understood.
Thank you. So there's just been another comment in the chat from Caroline. 2 questions in here. So what outcome measures of the triple aim have been used so far in local projects? And the second one, which I was actually going to ask too, which was, is teaching of family practice residents and medical students part of the project? So I will touch on the second one first, if I may. And just from the ISU's perspective, so our project that hosts these webinars, our 2 partner sites are both connected deeply with 2 of our training sites in communities in BC. And I can see Mark McKenzie's smiling face in a little window here, who is our program director for postgrad, so for the family medicine residency training program. So very much training is a piece of this. And in fact, you know, anecdotally in Victoria, we see, I know of 3 family practice residents that have gone back into community practice, and more than that have gone out of community into the hospital, and those 3 are all working at a team-based practice, which sort of, it speaks that way. And Nanaimo is one of our partner groups, very much is thinking about this as a way of engaging learners, teaching them how to do team-based practice from the beginning, and then keep them in community, which is a critical part of this. So there's that piece. And then in terms of evaluation and outcomes, that's, I think, one of our next discussions. And certainly the triple aim, or, you know, the various flavors of the quadruple aim are a key piece of what evaluation needs to be considered going forward.
If I could just add to that, in terms of the stakeholder engagement that I did, everybody who was able to speak to their evaluation plans or evaluation needs made reference to the triple aim or quadruple aim, depending on who we're talking to.
I'm aware of time, and we're just about at the hour. This has been a wonderful discussion. I love that we try to present with sort of 10 slides, and that just spurs a big discussion. That's exactly what we wanted to do with these sessions. I wanted to do a quick announcement before we wrap up, which is to say that there's going to be another email coming from the ISU shortly with an invitation to a different presentation. It's going to be held on March the 6th at, I believe, 4 o'clock. And it'll be somebody, Dr. Price from Ontario, who's going to be presenting on some of his experiences with team-based care and changes that have happened in Ontario. He's no relation to me, but I hear he's a good speaker. So I bundle that under the ISU, and so expect an email for that, and that'll be our March presentation. I expect that'll be a little bit more of a full presentation as opposed to our shorter presentations and discussions. And then we'll sort of get back onto our regular track in April, May, and June. So I've collected, as always, post-it notes galore of notes, and I'll be feeding those into the ideas for other topics. If anybody has any more, if you want to volunteer or you want to volunteer a friend, please just send me an email, and I'll start to work with them to get them to come and present.
Morgan, it's Louise. Is it fair to, just given, you know, I'm conscious of the time imperative and that people really are trying to move in a direction. Is it fair to say that with particular questions, they could contact you and you could funnel them out to
Yep,
see the
absolutely.
way at least sooner than later, because, you know, I think there is a need to try and assist as quickly as possible, even if we don't have all the answers yet and all the resources in place. And
Exactly.
yet you're only one person, but you have a team working with you. You know what, and I think you and Victoria will be talking, so you'll know what Victoria potentially can offer. Ultimately, when I get back from my holiday, I'm happy to be the recipient as well as any emails, and I think Christy would be as well. So it's not as if we're saying see you in a month. I think there needs some conversations sooner than later to help.
So one of the things that we have planned, and I just haven't gotten up yet, is some sort of forum so we can have these kind of between discussions. And it sounds like now, even more than a first meeting, that's important. So that might be something that we have to
thank you.
Cycle back to, and just to have an email / something forum that we can share stuff.
Yes.
Yeah.
Okay. All right.
Hear, hear.
Thank you, Morgan.
All right. Thank you, everybody.
All right.
Thank you all.
Okay. Take care and have a good couple of weeks. And then, fire me questions.